They're at the other end.
He's trying to figure out how to get his microphone.
Happy birthday. Sorry, Darren, I didn't mean to tax your, IT ability there.
The best part was today.
If maybe you could just do some sort of.
Can you hear me now?
Yeah, you're good.
Okay.
I know all times. The more seats
I'll
I get,
unmute now.
the better you'll be able to speak. So.
Do you say anything, Chief?
I don't, if you're ready to go. I was gonna do what you were gonna do, just a short intro, so you got it.
Okay, good deal. We'll go ahead and get going then. Thanks very much. All right, so I'm Dr. Hodges. I'm Kevin Hodges. I'm your medical program director. I actually recognize most of you. Some of you I see more often than others. And then, and this is my partner, AJ Fondrick. And so a little bit about me first. I'll let AJ introduce a little bit more about him. So in case you don't know me very well or don't know my history, is that I started before I went to medical school. I went to EMT school at Portland Community College because a friend of mine said, "What are you going to do?" I said, "I want to be a doctor." He says, "Well, do you like medicine?" I'm like, "Well, I don't actually know, but it sounds good." He said, "That's a lot of school to figure out you don't like medicine." I said, "You're right." He said, so he was just finishing his paramedic class. He said, "So you should do an EMT class." So I signed up for an EMT class and I really liked it. So I signed up immediately for a paramedic class because you could do that. And really liked that. So I became a paramedic and I worked in Multnomah and Clackamas County over in Portland. Then as soon as I could transfer, I transferred up to Clark County, which is Vancouver, across the river in Washington, because the protocols were so much better, or so much more advanced. And the medical program director there is Lynn Whitwer, and was then and still is, just a legend in EMS in the Northwest and in general, and has really helped shape a lot of EMS in Washington State. Policy-wise, law-wise, and just as an example for a lot of us. So he's been my mentor for years. But then I went to medical school, and I went to medical school at Creighton University School of Medicine, which is Omaha, Nebraska, which is a good Catholic school. And I did my undergrad in chemistry at the University of Portland in Portland, which is a good Holy Cross Catholic school. And I'm not Catholic, by the way, I'm Lutheran, so I'm not really sure what that means. That's like Catholic, all the guilt but no pope is what I think is what it really means. But, and I did emergency medicine, thinking I wanted to be a medical program director. So I did emergency medicine residency at Summa Health System in Akron, Ohio. There's a level 1 trauma center there and a level 1 pediatric trauma center there. And then I liked it so much, I did additional training in University of Maryland, Baltimore shock trauma, doing trauma and critical care. And that I hated almost every minute of, but I really appreciated it. I learned a lot there. But I haven't been to Baltimore since, and don't plan to go back. I understand maybe I didn't see the best side of Baltimore, but at the trauma center, but it was not a good side. But then my wife, who I had met in Portland, drew a circle around Portland on a map and said, "Get a job anywhere in this area." And because we're moving back to the Northwest. It was a pretty generous circle. We had like North Tahoe, I think, was at the bottom of the circle. And so I looked around and I was looking for places where I felt like it'd make a difference. I wanted to do academic type stuff. I wanted to do EMS. And I ended up in the Tri-Cities, which is where I was born. Actually, I was born at Cadlick. I graduated from Kamiakin. And I turned 18 and got the hell out of Dodge, said I'd never come back. But things change. Cities change, and the cities look a little different when you got 4 kids and some age on you. But as soon as Dr. Luera heard about me, says he was interested in stepping down, had been the MPD here for about 15 years, for those of you who remember him, and was getting kind of tired of it, was a little bit done, wanted to kind of back down a little bit, and so he let me take over. And man, what a fun system. It's been a great ride. That was in 2008, I think, which kind of scares me because that means I've been the MPD now for almost 14 years. So, and I love it. I love it. It doesn't pay very well, but I get a lot of energy from it. I get a lot of personal satisfaction from it. So I wanted to tell you a little bit about me. I'll tell you why we're here. Lonnie asked, you guys have started doing transports. And so that transition from a mostly BLS with some ILS capability to a transport capability is huge. And then when you start adding things like ALS capabilities, whether it's 24 hours a day or not, but just to do any ALS capability is a big reach or a big change and a big stretch for a department. And so it was pretty bold. I thought it was blankly pretty ballsy to have that kind of vision and to say, yeah, I'm going to take Benton County Fire District 1 and I am going to turn this into not just a transporting agency, but an ALS capable transporting agency. And that was pretty remarkable. My experience with the fire departments in general is we joke sometimes that we measure progress one retirement at a time, because culture and history tend to dictate what happens in some organizations. And I just don't see that as much here. You have an interested and you have a dynamic chief and set of deputy chiefs, and you got new medics, and you got this fantastic new program with a lot of people who are really enthused about it. You got Captain Henderson, who's just grabbed this by the reins and trying to do what we can to put together something good. And so talking with Lonnie, who said there's going to be a certain amount of growing pains, with any kind of radical change, whether it's fire department or what. And that's two radical changes, not just transport, but ALS capabilities as well. And so why don't we put some extra effort into it with some direct contact with the MPD and some experienced paramedics or paramedic, and say, let's take this time. We know there's going to be some growing pains, and let's just make sure that we get the most possible out of that. And at the end of this run, that we have, instead of making all the mistakes and fighting through it and fighting each other about it, is that we learn from this, and at the end of that, we have a really smooth, well-oiled, good teamwork type of a program, both for transport and for ALS, and for the ILS and the BLS transports as well, which are still happening, of course, which I think is really cool. It's not just the paramedics who are doing all the transports, right? And it's not going to be, maybe someday, but that's probably not a sustainable model, at least in the current situation. So having highly trained, high quality EMTs and AEMTs is going to be a big part of this, the success of this department and this new program. So we're not here for any kind of radical changes. We're not here to countermand anything, all the good that's been done already, or to upset any of the status quo. We're not here because we're bored. I guarantee I have plenty to do, but this is important, and this is worth my time. But you're doing something new, so we want to foster a program that's learning this new thing, and in the next few months to year or so, to take it from the great stuff you've already done and to turn it into something really smooth and well-oiled, that suits the needs of the people that we're running on calls for, right? The people that are paying their tax money and or calling 911 for us, right? Suits the need of your employer because somebody's paying you for this, right? Or if you're a volunteer, then God bless you. I appreciate that. That's wonderful. But also, so from the billing side, from the business side of a fire department, which is a fact, whether we like it or not, to the medicine side to make the MPD happy, the billing side to make April happy, and then for you guys, so you guys have as much satisfaction out of your jobs as possible, and to make it as smooth and enjoyable as possible. I like to work in the emergency department, but there's some headaches there, right? And so I like to work at the freestanding. There's headaches there too, but they're different headaches. and different headaches are nice sometimes, right? Being the MPD creates some headaches, but those are different headaches. And the benefits I get from it outweigh those. So we're here to foster teamwork and some consistency and really to make your guys' job easier. And so at Lonnie's request. We're going to be working with you a lot, especially over the next 3 months and certainly over the next year. And when I say you, I mean everybody, not just the ALS providers, but literally everybody. So we want to see what we can do to make your job easier and smoother, and make it easier for you guys to please the people you got to please, which is the MPD, which is the chief, which is the billing people, which is yourself, right? Your families, your partners, and be the machine that I think you guys can be. To start with, before I let AJ take over for a second, is what I want to do is I want to hear from each of you guys. If you don't want to talk to me, that's fine. But I want to talk at some point in the next couple of months. I'm going to talk to every single person in this room, every single person in the department, if I can, because I want your take, whether you've been with the department for 20 years, or whether you are a brand new resident, or whether you started volunteering the day before yesterday and got roped into this meeting. I want to hear a little bit about, I want to talk to you, and I want to hear a little bit about your experiences, what you like, what you'd like to see, if you could change something, those types of things. I want to find that out. We're going to sit down and we're going to chat with me, if you'll chat with me. If you're willing, I'm just going to pass this around and just put your name, certification level, email if you want me to contact you by email, phone if you want me to contact you by phone. If you don't feel comfortable writing anything there, this is my email here, and this is my personal cell phone. All right, so you guys have access to me. If you call me at 3 in the morning, dude, I'm an emergency doctor, I might answer. All right, I might be there, or I might be sleeping. But send me a text, that's fine. But I'll be contacting you, and the people who are interested and want to, I'll be contacting first. So I want to let you know a little bit about why we're here. Tonight, we're going to start talking about charting and some billing. And I got to say, I like a lot of the stuff I've seen already from your guys' charts. And I think you'll see that when we talk to AJ. But I'm going to introduce AJ Fodrick. He's a firefighter paramedic from Kennewick Fire, and he's my paramedic MPD assistant. So I pay this guy to help me out. And don't tell him, but he's worth every penny. So,
I've seen most of you. My name's AJ. I'm a paramedic with the Kennewick Fire Department. I got hired here in 2014, so I've worked with you guys since January of 2014. So some of you were here then, some of you weren't. But like Dr. Hodges said, we started looking at reports, and we were just talking the night before the meeting. A lot has changed in the 8 years, and both of us are impressed. But I remember going on calls with you guys when, there were no ambulances here, there was no transporting, no ALS, no ILS, and it's come a long ways, and I'm impressed. So I just want to say good job to everyone. A little bit about my background. I grew up in a little town in Montana. I started volunteering at a volunteer fire department, and we ran 82 calls, I think, the first year I was there. No EMS calls, we didn't do that. I moved to the west side, and I was a resident in Maple Valley for 5 years. Then I moved to Yakima, and I worked for a private ambulance company there for 5 years and went to paramedic school in Vancouver under Dr. Whitworth. And then I got hired here. So I've kind of been all over. I started in a little tiny town in Montana. I worked on the west side. I learned in Vancouver, and now I work here. So not near as extensive as his schooling, but
that's just because I'm older.
So I'm excited to help you guys out in any way we can. I've been in the same exact spot where I was learning new things, doing things we hadn't done before. So hopefully we can help out with that.
You need a minute to pull up the chart?
Yeah.
All right. So I want to point out, I wore this shirt on purpose for good luck. So Cuyahoga Falls, it's hard to pronounce, I guess. Cuyahoga Falls is the first agency that I had any role with as NPD, and I was assisting the full-time NPD And the guys are just fantastic. And it's a suburb just a little bit north of Akron, for those of you who care. But it was my very first experience doing any kind of MPD type work while I was a senior emergency resident in Akron. And I had just a fantastic experience with them. I learned a ton. I did a lot of ride time with them. The system is very different. And so to be able to compare what's the capabilities of a paramedic in the Northwest and Washington and in Benton Franklin counties, for example, versus what they can do over there is a lot different. And to give you an example, the level of commitment that the state of Washington and that the local areas put in, if you want to be a paramedic, you may not know it, but the National Registry says you need at least, in order to qualify, you need at least 600 hours of training. All right. In Washington State, in order to be a paramedic, you need 2,400 to 2,700 hours of training. And so the level of paramedic that I saw over there was very comparable to the AEMTs and the abilities that I see over here. And what I can do with ALS providers and EMTs and AEMTs here are well above what I could do over there. And I banged my head against that a lot when I was in Ohio. And then I come back here and say, oh, thank God, I have real EMS providers again. And so the protocols that you read that we're writing and the level of quality of care that we're able to provide pre-hospitally in this area is because of the level of training that you guys get. Every time we tried in Ohio to get the level of training come up, the chiefs are like, no, I don't want to pay. I'm not going to pay my guys for an extra 100 hours of training or an extra 50 hours of training. That's a lot of money. And I'd rather buy a shiny new ladder truck or something. But the people here are so committed to EMS that we have fantastic EMT and paramedic and AEMT programs, continuing ed, and the Washington standards are so high. So, you ready?
Yep.
All right. I'm gonna grab a coffee. The topic of today is going to be documentation. I asked AJ to grab a chart or two, and I want him to run through a chart as a paramedic. This is District 1 chart, right?
Yes.
Yeah, perfect.
So I forgot to say, in 2011, when I worked in Yakima, before I went to paramedic school, I started as the EMS cares representative. So since 2011, I've reviewed every single cardiac arrest report in Yakima County. I still do that today, but now I do it in Benton, Franklin, and Adams counties as well. So if you want tips on cardiac arrest charts.
Told you it was worth the money.
So we already talked about what we're gonna do. So something I was telling Dr. Hodges when we got here earlier, I struggled with the SOAP format when I first started. And now I think it's very simple. Certain things go certain places. And it's something that I help new people with at KFD all the time when they get hired. So I want to help if anyone's struggling with that. Hopefully I can help with that. I want everyone to take a minute and read this report.
Big enough for everybody?
Nope.
Bigger scroll button. I don't know how to do that now.
Control scroll wheel?
I don't have a scroll
We
wheel.
can't see that on the, hey Scott, we can't see that on the display.
You can't
on the
see it
Zoom.
anymore. It's too small.
No, all I see is the PowerPoint.
You didn't, because you had it set to just the PowerPoints, you didn't have your screen for.
Oh, geez.
I did have my screen share. It just didn't share that. That make any difference?
Yep, there it is. Thank you.
I can't make it any bigger, sorry. I'm not that smart.
Can you just read it to us?
Try Control plus.
Oh, yeah, maybe that'll work.
Good thought. I guess we'll just have to read it like this.
I can go make copies.
Oh, yeah.
30
Okay.
copies of them.
Why don't you read it to him?
So aide 1122 were dispatched to an 84-year-old male with generalized weakness. Upon arrival, the patient reported that he was feeling weak since his fall a week ago. Patient reported that he did go to the doctor after the fall. They gave him a sling for his left arm and sent him home. The patient's daughter reported that he appears to be losing his memory. The patient's daughter reported that she was concerned about getting into the car by herself with how weak he was. The patient's daughter reported that he has a doctor's appointment later in the day for a follow-up at Trios. The patient denied having any new pain development from the fall. Patient denied any shortness of breath, abdominal pain, neck pain, loss of consciousness. Patient denied any new in his back, I would assume new pain in his back and left shoulder from his fall a week prior. Patient's daughter reported that he has been having bladder control, and has wet himself over the past week. Patient's daughter reported that she thinks he had a seizure in December where he stared off into space and accidentally wet himself. So we have past medical history of seizures, falls, bladder disorder, and a pacemaker. For medications, see the flow chart below. Allergies, he's allergic to sulfa. Our objective, upon arrival, the patient was found sitting in his recliner up straight and did not appear to be in any immediate distress. The patient was ANO 4 out of 4 with a GCS of 15. Patient assessment was as follows. Skin was warm, pink, and dry. He is normocephalic for his head, ears, eyes, nose, and throat. Neck, no JVD, and his trachea was midline. Chest, equal rise and fall bilaterally. Lung sounds were clear and equal bilaterally. Abdomen, denied having any pain. Pelvis, no complaints, no exam. Back, no abnormalities. Reported pain from his fall a week prior, but could manage it with position of comfort. Extremities were intact with distal PMS. Baseline vital signs. Blood pressure at 141/76, heart rate of 81, respirators are at 16, sugars 149, temp is 96.7, GCS of 15, setting 91% on room air. And after they gave him O2 via nasal cannula at 3 liters per minute, he came up to 98%. Assessment is generalized weakness secondary to a fall a week prior. Plan is 8/11/22 responded with no lights and sirens, arrived on scene and obtained patient report, performed patient assessment and obtained baseline vital signs, see flow chart, assisted patient to the stretcher via walking 4 feet, secured with all straps and rails, raised semi-Fowler sitting up, loaded the patient into the ambulance without incident. 8/11/22 placed the patient on O2 via nasal cannula at 3 liters per minute for low O2 sat, observed the patient's O2 sat rise to 98%. 8/11/22 went en route to Trios with no lights and sirens, obtained trending vital signs, see flow chart, kept patient in position of comfort. 8/11/22 called report to Trios ERRN without any further questions or directives. 8/11/22 arrived at Trios ER and moved the patient inside via stretcher, moved to the hospital bed via sheet move, and transferred patient care to ERRN in room 18 without incident. So I want everyone to remember that, because once we're done, we're going to come back and look at it again. Yep. So this is a little bit redundant. This is the protocol exactly how it's written. So I'm going to have these up here. And if you're watching this on a recording, you can pause this and read them. But we're going to move forward and I'm going to talk about how I remember. So you're subjective. And if you have a pen, write this down. You can write down how to write a SOAP with a quarter of a sheet of paper. Your subjective is anything that anyone told you. If someone tells you something, that's a subjective finding. whether that's dispatch, a bystander, family member, the patient. It also starts with what we are dispatched to, and that's part of the billing component. So were we called by 911 or was it a private call? And did we respond code 2 or 3? Part of our subjective findings are pertinent negatives. So if we take a patient into the ER and they ended up complaining of chest pain to them, and we didn't write that they denied chest pain to us, then we never asked them that. So in that last report we looked at, denied shortness of breath, abdominal pain, anything else. This one's my favorite, and it's something that comes up a lot and people don't know how to document it. If you show up to someone's house and they're sitting in their chair on their phone and you're asking them about their foot pain, you say, on a scale from 1 to 10, how bad is it? Oh, it's a 10 for sure. Are they having 10 out of 10 pain?
Nope.
No. But did they say they're having 10 out of 10 pain?
Yes.
Yes. So we can't change what they're saying. It's our responsibility to paint the picture. So your objective is anything we find. So that's the age, sex of the patient, patient's level of consciousness, location, positioning of the patient, and this is all what's pertinent. So were they face down on the kitchen floor, upside down in a well, or sitting in a recliner watching TV? Complaining of 10 out of 10. Physical findings and body systems, anything else you found or see that's pertinent to the call. So if you walk into someone's kitchen and there's an empty beer can on the counter, that's not really pertinent if you're there for chest pain. But if you walk in and it's the person's unconscious and there's 3 bottles of wine laying next to them that are empty, that's pertinent. So you don't have to describe everything, describe what's important to this call. With our objective, we're trying to paint a picture. So if I'm on the call and he wasn't, he can look at my report. And as he's reading, he's going, okay, I'm following. I can see what he's explaining. So paint that picture. We already talked about the pain. Your assessment. This is your diagnosis of the patient. So we're saying this is what's happening and this is what's wrong with them. If you look in the protocol, it says you can do a 2-part assessment, and that's what I prefer to do. So if someone's complaining of chest pain and they have ST elevation in their EKG, I'm going to write chest pain secondary to whatever type of MI they're having. That's how I like to do it. It kind of gives you options to do it different ways, but we are diagnosing the patient. Dr. Hodges wants us to diagnose the patient, and we're not always going to be right. And that's okay. But he wants us to make our diagnosis. With that, our treatment should match our diagnosis. So if you're treating someone for an asthma attack, our report should follow that. Our assessment should say shortness of breath, secondary to. I like to put asthma exacerbation. That's a term that I like. They have asthma and it's being exacerbated. We can't talk about their leg pain. Well, you gave them a nebulizer, you gave Solumedrol, you gave all this other stuff, but you're describing that you're taking him in for his knee pain. So everything in our chart should go back to our assessment. We're diagnosing them with this problem, and there can be multiple things wrong. And you can have multiple assessments. So you could have your first one. You have your A. Say you have shortness of breath, secondary to asthma exacerbation. you can drop down a line and then you can write something else. And if there were a couple of things, you can write something else. You don't want to make those 10 long. But if there's more than one thing going on, you can have more than one diagnosis. And then your plan. And there's different formats for this. Like we saw one report already, where it's just one line. They drop down the next line for the next thing they did. But all your plan is everything you did. And we want that in chronological order. So we should be able to look at that. And that's the beginning of the call. And I just write mine in, it's sometimes a run-on sentence, but I don't drop down the lines. I just write it in one big paragraph. That's how I prefer to write it. A lot of people prefer to write it how we saw it. And there's no right or wrong, it's just your style. And just because I write my reports one way and you write yours one way, it doesn't make one of us right and one of us wrong. They're different styles. All the information is there, they're just there in different ways. So did we check a blood sugar? Did we secure the patient to the stretcher like we saw in here? We used all the belts and the rails. Leave their belongings or paperwork in the ER. So I normally work at Station 4 now, but when we take people from the Kirk to main campus, they always give us a big packet of paperwork. Paperwork's not for us, it's for the receiving physician. So if the receiving physician doesn't get it, where did it go? Well, I left it with them, and that's in my report, that we took one personal bag, we left that there. We also gave the nurse or physician the paperwork that the Kirk gave us. So that way that's all documented. Did we put them on oxygen? What did we use to administer the oxygen? How much did we give them? Did we give them any medication? If we did, we need to have the amount and the route we gave it to them. And did you give a verbal report to the RN in the room when you dropped them off? We saw in here, and that's something that I like to put, is if we move someone, we moved them from our gurney to the ER bed without incident. So we moved them and there were no problems. If there wasn't, if we drop them on the floor, then I need to write that. Like that video that's going around from the band.
What's your allowance on, or what's the typical allowance on shorthand? Because obviously, as you're writing up here on your assessment, that was a very shorthand, shortness of breath, secondary to asthma exacerbation. And you did that in not necessarily even what amounts to 4 words. So,
So if are you asking about abbreviations I'm using?
yes,
Okay, so there's actually a list in the protocol book.
yeah, so,
So if you have a question, say there's one that you like to use, we have new people that get hired and we start reading their reports and we're like, what is this? And they say what it is, we're like, I've never heard of that, but you can't use that. Why? I've used it forever because it's not in the protocol book. If you want the protocol book, you are more than welcome to come and we can look at adding it. But the approved abbreviations are in the protocol book.
okay, so we can shorthand as long as we're.
Yep,
using
as
that
long as
word.
it's in there. And if it's not, and it's something you want put in, then the next time the protocol committee meets, we can look at that as well.
Yeah, the ultimate test is, can somebody who is not you and or your partner read that and know exactly what you're talking about? And if almost everybody can, that's probably good, right? But if it's something you've used and you've always used, but I don't know what it means when I read it, neither does AJ and neither does Samantha, we should probably do something different. All right, rather than teaching everybody else in the county that particular abbreviation, why don't you just change something? You know? But the ultimate test is, can somebody else read it and know exactly what you're saying? Yes, IV. I don't know what that means. NS, normal saline. Okay, fine. You know, GCS. Oh, that's my coma score. I got you. Yeah, we're good, right? You know,
So I felt like this deserves its own slide. They talk about this whether you go to first responder, EMT, AEMT, paramedic, you become a physician, whatever. If you don't write it down in your report, it never happens. And it catches people all the time. So we want to have good, solid documentation. Billing. I got a hint that the billing person is on here. Is that accurate? So everyone has a billing department. It's part of what we do. We bill for our services. It's expensive, right? That everything's expensive we use. The ambulances we drive there are expensive. The equipment we use is expensive. Everything's expensive. So we bill for that. There are certain things we have to have because there's rules, laws, and the billing person would obviously know a lot more about that than me. I know what we need to put in there. If you don't put it in there, they'll contact you. And you'll put it in there from then on. So a couple things that we saw, signatures, the patient and the crew, you need that. Obviously, if someone's unconscious, we have a button for that. The patient doesn't need to sign. Medical necessity. Your report should reflect on why we're transporting them. I had a perfect one last night. I worked at Station 1. We were downtown and we went on a patient that I had seen before that demanded we take them to the hospital. But they didn't have a complaint. I can't take you to the hospital if you don't have a complaint. So then they had leg cramps. But that's why I'm taking you to the hospital. If you demand that I take you to the hospital, I can't tell you no. But you have to give me a reason why I'm taking you there. And then PCS forms. If you do a non-emergency transport, which I don't think you guys would you guys do that?
They said we don't need PCS forms. We do not do non-emergency,
Okay, I didn't think so, but I saw it in there, and so if we needed to, but
which is also why their narratives, they have to use the verbiage lights and sirens or no lights and sirens because it conflicts with the immediate response tabs and the emergent and non-emergent tabs.
perfect. So if you were doing that, say AMR, for example, they do non-emergency transports. They have to get a special form that's signed by a physician saying they need to be transported by ambulance for this reason. So if you ever run into that, I'm sure that they'll tell you beforehand, but you would need that. Okay. So we went through that real quick. Go ahead, Doc.
I was gonna say, we want to come back to that
We can.
after mine.
This is the same one that we just went over.
Right, yeah.
Let me skip it. I'm gonna talk about examples and templates real quick, and that's the last thing I have.
Okay.
So we have examples and we have templates. I talked to Captain Henderson about this. I use a template. I'm gonna show you the template I use after Dr. Hodges' lecture. But if it's an example and it has stuff already filled in, I recommend that you do not use that. You run the risk of forgetting to delete something. Remember, we talked about if you don't write something down, it never happened. But if you have something written down that didn't happen as well, that kind of takes your credibility away. So if you're very first starting out, you've never written a report before, it would be easy to take that example and I'm just gonna copy and paste this in here, right? Because if you sit down with a blank piece of paper and you type your entire narrative out, it's gonna take you forever, isn't it? The first time. You'll be a little faster the second time, faster the third time, but you eventually get a lot faster. So when you're very first starting out, it takes a long time, but take that time, learn how to do it right, and I promise you, you will be great at it.
And it'll save you so much time in the long run.
Yes.
Good charting habits early on. And a lot of you have, I read a lot of your charts. Not to frighten you.
So I don't know can they see you when you write a report, Sam? Do they all say, oh man, you can write a report way faster than me?
If
But-
you haven't done before we get back from the hospital.
How many reports has she written?
Oh.
Yeah. So if you've written 5 reports, it's like, man, that takes me 45 minutes to do. And she just did it in 5 minutes. Well, once you've done a couple hundred of them or over 1,000 of them, it makes it a lot faster. And if you learn how to do it correctly in the very beginning, then as you get faster, you're never going to lose that. We talked about legality a little bit. That's my soap, but we can just go over it real quick. It takes 2 seconds. That's what I start with when I write a report. And if I'm at the hospital and it was a critical call, I can start with nothing. I can just type it into image trend. It's nothing fancy. It's little things like the formatting of it that I can jump to it a little bit faster. This is already here, but it's nothing fancy. I have to write down exactly what happened. I don't write a report fast because it's all half done. I write it fast because I've written hundreds of them. So that's all I use. That's it. If you've never written a report before, using that is going to take you a little bit longer, but you'll get faster, you'll get more comfortable.
Yeah, so a note on templates, which is some good, he brought up some of the same points, almost like we're reinforcing each other. There's a danger in a template, okay? But there's uses in a template too, especially the earlier you are in your progress and the less notes you've written, you can use that. The cut and paste saves you a lot of time, but there are some dangers with it. And he mentioned, just same as documenting something that wasn't there that I didn't check or similar. Here's what I see a lot when I see people cutting and pasting templates. And that is pupils equal round and react to light on blind people. All right. Pulse sensation and movement in all four extremities on people with bilateral below the knee amputations. All right. And so obviously that's not right. And it doesn't look good. Right. It's a little bit sloppy. We want to make sure we're recording what's going on, but also not recording what we didn't do. If you didn't do a back exam on the patient, don't put a back exam down, right? And so if you're going to use a template and they have some value, but they carry some risks, I agree with mostly with AJ. But if you're going to use a template, you can use a template, but be aware of the limitations of that template and be careful that you're not making those types of easy mistakes, right? It always says this physical exam, and that's just not the case. So like for me, when I write templates, I have templates. I have a template on my computer for almost every major chief complaint that I get in the emergency department. I have a chest pain complaint. I have a shortness of breath complaint. I have an upper respiratory infection complaint. I have a pediatric illness complaint. I have a pediatric head injury complaint. And yes, that's because I'm charting those 30 times a day, when I'm at work. And it saves me time over the long run to literally write 35 different templates and with a bunch of blanks in it. So AJ's template is a generic template. Boom, here it is. There's lots of correct ways to do things, but know the inherent limitations and the problems of those, of the one you choose. Alrighty. The other thing about charting, why do we care about charting? Not just because it pays the bills, right? And because the chief says we have to do so, but because charting influences patient care. Why do I care that I'm getting good charts from you guys that I'm reading them? Because I know that a good chart correlates to good patient care, right? How you document influences how you do patient care. If my template on a pregnant vaginal bleed patient, for example, always on my template, it says a little blank spot after how many times they've been pregnant, how many kids they had, how many miscarriages they had, then I'm going to ask that question every time because that's an important question. If I miss it, I go back to the template. Oh, yeah, that's right. Okay, I better ask that question. Go back to the patient, ask the question, right? And so charting influences my patient care, and my patient care influences my charting. The things that make a difference in my patient care, I'm going to make sure get into my chart. So those go hand in hand. There is no such thing as a good EMS provider who can't write a good chart. There is no such thing as that. All right. To be a good EMS provider, you need to be able to write a good chart. So who are you writing the chart for, right? Well, what is it? It's a record of what happened, right? And there's an art to doing so. Does the perfect chart exist? Man, I don't know. If so, I've never written one. And I've been an EMT and or a paramedic since 1994, 93 maybe. God, a long time, right? And a physician, since 2003. I've written a lot of charts. And does a perfect chart exist? I don't know, but I'll keep going for one. And I can tell you, even if the perfect chart doesn't exist, that doesn't mean one chart's not better than another chart. All right, and we've all seen that. I need to see what, be able to read a chart and see it's a record of what happened. It's also a medical legal record, right? If you're ever in court or it's subpoenaed, an assault case, right? How often do you think there's a lawyer, a police officer, or multiple lawyers reading your charts? More often than you realize. More often than you realize. Anybody ever here had to be in court when their chart was put up and testify? Yeah, me many times. And that's a really bad time to realize you misspelled something like hernia. All right. Or can't write a coherent chart. So, I mean, I'm not saying chart, just solely because what it's going to look like in court, right? But that is a gauge, right? I want to be able to make something that's a medical legal record and be proud of that or be okay with it. But it's also, and this is something you can't fight, it's a billing aid, right? Who makes all of the EMS electronic medical records and the hospital electronic medical records? Who makes those? And who buys those? Well, your agency buys that, right? Or the hospital buys that program or access to that program, and they buy it. Why? Because they are told it will improve their billing, right? And because if we have this element, this element, this element, this element, then that meets the Center for Medicare and Medicaid's requirements to bill for this, for an ALS chart or a BLS chart or an ILS chart or an emergency transport chart. Who cares if you went lights and sirens or not? I don't. I'm your medical program director. I don't. Who does? The billing department does, because it's a different bill. All right. And that's just a fact. If you guys aren't supporting your billing department, you're not supporting your own job, right? So there's some things you can change and there's some things you can't change, right? So April says, God, we got to have the Center for, or this insurance company always requires this piece of information. So I really need this in your chart. Yeah, I can't change that. Sure, whatever. I'll put that in my chart, right? If Chief Click comes in and says, I want you to always document whether you went lights and sirens or not. I don't care why, right? Chief Click said, I got to chart this. That's fine. And that's easy. And that's going to change the thing. I recognize that my chart is not just like I would like to see it as a medical care provider of a record of medically what happened, right? But I know that my chart affects my billing, which affects my paycheck, right? And you guys, it's the same way. Your chart affects your department's ability to bill, which affects your paycheck, right? And your job. Budget cuts in the department are going to affect people too, right? So I'm not saying we ever want to bill for something we didn't do, but I want to get paid for what I did. And I want my department to get paid for what we did. So that's what who's it for. Some things you just can't fight. And that's an example of that emergency, non-emergency. But that templates can be very useful. And I use templates, but you have to recognize the limitations of a template. All right. If you're using an example, that's what G7 is, right? Why is that example in there in such detail in G7 is because that's a great example of one correct way to do a chart and gives you an example of the information that I need to see in there. The ideal chart is going to be an accurate representation of what happened on the call, what was going on with the patient, right? And your medical decision-making during that call. It looked like this, but then I thought I saw this and I thought it was this, but now I think it's this. And so we did this, 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 and this, right? Or this is what led me to that assessment, and this is what we did about it. And that should flow naturally, but it shouldn't be 12 pages long. Because do you want to write a 12-page chart? No, you do not. And I don't want to read a 12-page chart. All right. I want a few paragraphs with some really high quality information. Where you're giving me a verbal report in the emergency department. How many of you guys have given me a verbal report in the emergency department on a patient care handle? Lots of you guys, right? What happens after about 20 seconds? My ADHD kicks in and my eyes glaze over, right? So Dr. Hodges has a low attention span because it says emergency medicine right on the chest, right? Dr. Hodges has low attention span, so I got to get the maximum amount of high quality information as possible. And that's how I think of my chart. I don't want to write a 12-page chart, but I want to write an accurate chart that portrays, that paints the picture, as AJ said, of what was going on and what happened. So how do I do that? How do I include medical decision-making? How do I put the reader in my mind and able to come to the same conclusions that I came to? That's what I need to find out, right? I'm gonna erase a couple of these things just because I want a little space. All right, AJ, you don't exist anymore. So this is how I approach charting. And there's a lot of ways to correctly do a chart, but they're gonna have to have those elements, right? They gotta satisfy the medical legal side, they gotta satisfy the patient care side, they gotta satisfy the billing side. So I look at a chart like this, okay? I'm gonna start at the top and work my way down. So when I do, I love the SOAP format, right? So subjective, objective, assessment, and plan, for those of you who aren't as familiar with it. So subjective, like he said, is those are things that somebody told me. If I ask you, are you short of breath? And you say yes, subjectively, he's short of breath, right? If I see him with a respiratory rate of 44, tripoding, leaning over, jugular venous distension, straining, retractions, he is objectively short of breath. I saw that for myself, right? Or objectively having difficulty breathing. Okay. In the example that AJ gave, the guy sitting there flipping on the phone, eating flaming hot Cheetos, complaining of 10 out of 10 abdominal pain. Do they have 10 out of 10 abdominal pain? Yes, they do, because that's subjective. And they told you they had 10 out of 10 abdominal pain. Objectively, what did you see? The patient sitting there appears relaxed, does not appear in any distress, eating flaming hot Cheetos during the exam, right? So see how the difference in the picture? Subjectively, patient has abdominal pain, patient has 10 out of 10 pain. Objectively, this is what I actually saw. When I pressed on their belly, it did not seem to cause any, there was no tenderness, there was no guarding, those kind of things, right? And the opposite happens too. You get the tough guys. How bad is that pain? That's a 2. Really? Because you're missing most of that left arm, so I guess that's cool that it doesn't hurt that bad, but can I give you some morphine to make me feel better? So subjectively, what's somebody telling? But we got to get on the same page right away, right? So when you look at the G7 protocol, you see there's a specific list of things I want right away. What are some billing things? Well, was it lights and sirens? Was it code 3? Was it code 2? How did you get there, right? To what kind of call came down? It came down as a breathing difficulty, or it came down as a public assist, or a man down, or whatever, I don't know, whatever it was, right? Chest pain. And so those are billing type information, right? But then there's that next sentence, that really good sentence at the very top of the subjective that says age, right? Gender, pertinent past medical history, PPM, this is terrible. Pertinent past medical history and chief complaint. Have you ever been getting a story from somebody or getting a patient your hand off at the scene? Hey, we got a person in this car, blah, 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 blah. I want you to go take care of the one in the Volkswagen. The driver was complaining or whatever, right? You guys do that all the time. You give handoffs to me. I can't tell you how many times I've been 5 minutes into a report about this patient with chest pain or something like that, and shortness of breath and all this stuff, before I realized it was a 15-year-old girl was the patient, all right? Because that takes me down a totally different path, right? This is a 15-year-old female with no significant medical history complaining of sudden onset chest pain, shortness of breath, while in an argument with her mother about her cell phone. Okay, one possible path, right? Because that same chief complaint is totally different when I say this is a 78-year-old female, 6 months after a bypass surgery, complaining of sudden onset crushing chest pain and shortness of breath while mowing her lawn. I don't know why she was mowing the lawn at her age and her medical condition, but she was, right? But it's not just a totally different path, right? So boom, this high yield, immediate information, right, gets us all on the same page, and everything flows from that. So I want that stuff right away. The next part is what we call, I would call it the intro, right? And I call it the HPI, the history of the present illness. Just a few sentences. What happened, right? Well, she was mowing the lawn, right? Mowing the lawn, and it was about 20 minutes into mowing the lawn. So she started feeling a pressure sensation in her chest, but she kept mowing the lawn. It got worse. She started getting short of breath. She sat down. The pain radiated the left shoulder. She sat down and rested for about 10 minutes, but it didn't go away. So she tried one of her nitroglycerin, waited 5 minutes. It didn't get any better. Tried another one. Waited 5 minutes, didn't get better. Tried another one. Didn't get any better, so she called 911. Oh, okay. So a little bit of, this is kind of what happened, right? It's not a long narrative, right? But hey, this tells us what was going on, what brought us to this position. And then we're also starting to think about things like, as he mentioned, pertinent negatives. When you say somebody's got chest pain, I also want to know, are they short of breath too? Right? Are they having nausea? Are they having vomiting? Right? Were they sweating? Now, there's a lot of things that make me think that chest pain patient who's 87 years old and has a history of 4 stents takes me down a pretty specific path. It's now a 37-year-old male who just had a knee surgery and had sudden onset sharp chest pain. That's a different path, right? I'm going down a pulmonary embolus. I'm going down a blood clot path now versus before. I'm definitely going down a cardiac path, right? Or the 17-year-old boy with, who breaks up with his girlfriend and he started having palpitations and shortness of breath. All right. Is he having chest pain and shortness of breath? Yes, he is. He just told you that's a subjective complaint, right? But we're on a different path as far as what is probably going to be the assessment. Much less likely to be an MI on that 17-year-old boy, right? Right. And probably not a blood clot. But, whatever. But the point is, we're funneling some things down. When I say I have this age, gender, pertinent past medical history, which might be none, no past medical history, and the chief complaint, that puts us on the same page. We're expecting something next, right? I'm expecting something from the history of present illness. And then I want to know a little bit about their past medical history. Maybe they're already on, maybe that was pertinent before, maybe I just put it here, right? The meds, those kind of things. I'm like, oh, are they already on aspirin? Oh, did they take aspirin today? I know maybe I don't need to give, they just took 325 aspirin before they called 911. Well, I probably don't need to be giving that if it's a chest pain complaint, those types of things, right? But it makes me look for something. Right now, in those cases that I gave you, in that 17-year-old boy whose girlfriend broke up with him and he started having palpitations and shortness of breath, what do you want to know about that guy's physical exam? What matters? Well, I'm kind of interested in his heart rate, right? Because an older person having an MI usually has a kind of a lower heart rate. But somebody in that situation, what would I expect is his heart rate to probably be elevated, right? Highly charged, maybe anxiety driven, maybe kind of state, right? I expect that to be elevated. What's his respiratory rate? Why do I care about his respiratory rate? Yeah, it's the hyperventilation. Maybe it's all part of the picture, right? I'm thinking about those things, but it makes you think. That just drove you to say, I want to know what his respiratory rate is. I want to know what his pulse ox is. Because I'm going to tell you what, if it's 100%, that's different than if it's 78%. Right now, all of a sudden, I'm like, well, you know what? Anxiety just went way down on that probability list. There's something going on there, right? I don't anxiety myself into a pulse ox of 78%, right? So, but I'm looking for that information. Well, how about the lung sounds? Anybody care about the lung sounds? Yeah. Well, hey, it turns out this kid's got a history of old Parkinson White, which gives him palpitations and tachydysrhythmias. Or he's got a history of asthma, and I got a bunch of wheezing now. Things are falling into place, right? So I'm looking for certain things, and that's the point. This is right here, and everything starts stemming from that. I get this. Oh, I want to know certain things about that HVI. Oh, that tells me. So I want to know a little bit about past. Oh, that tells me objectively. I want to know certain things about the vital signs and the physical exam. Altered mental status, one of the things you're looking at. I'm reading that chart saying this is a such and such is a 22-year-old male at a bachelor party. Altered mental status, friends couldn't wake him up. Right? Oh, okay. Well, this is making you think some things now, right? What are some of the things you're thinking? Could be alcohol, right? Could be drugs, trauma, or a combination of those. The guy got drunk, did a bunch of heroin, fell and hit his head before he stopped breathing, or whatever. I don't know. When AJ said you can have more than one diagnosis, usually there's more than one diagnosis. It'd be my experience. But it makes you immediately want to know some information, doesn't it? Right? Immediately I want to know, oh, is there any evidence of head trauma? Hey, what does that guy's pupils look like? Or what is his Glasgow score? Right? Of course, I always want to know vitals, right? But it makes you immediately, this is what I want to see, right? And that, now I have this, which led to this, which led to this, which led to this, and it should be obvious what's here. There's your assessment. That's your diagnosis. By the time you get to here, it should be obvious to everybody reading this chart what you're going to put right here. okay? It should be obvious, it's just a lead right to that. You are leading that reader to say, ah, this is definitely a panic attack, or this is definitely, as AJ was saying, anchoring with sometimes with the chief complaint. This is definitely palpitations, rapid palpitations, secondary to panic attack, if that's what you wanted to call it. Maybe a bad example, but totally legit. You could say palpitations, number one. Number two, panic attack. Number three, shortness of breath. I don't know, right? But all of those things, you just led right to it. And then you look at that, you say, well, now I have something I can work with, right? I use chest pain as my anchoring diagnosis, for example, on that 78-year-old. Number one, what's your thought on that 78-year-old that was 6 months or 6 months status post bypass surgery and was out mowing the lawn getting chest pain, shortness of breath? What's your number one thought after all of this? Let's say her lung sounds are okay. She was a little bradycardic, borderline hypotensive. What do you think?
Pulmonary embolism,
What's that?
pulmonary embolism potentially?
Pulmonary embolism is possible, right? How about MI? You think it might be your heart? That's got to be somewhere pretty high on that probability list, right? Right. So all these types of things. And if you thought it was a PE, if that was pulmonary embolism, put pulmonary embolism, or put chest pain secondary to PE, or chest pain possible PE, or chest pain probable PE. You get to clarify only after you anchored. So once you've anchored on a diagnosis, you can clarify as much as you want, okay? And you can phrase that however you want. Chest pain, suspect pulmonary embolism. Great. Why is that better than chest pain? Because one of the goals of your charting is to tell the reader what you were thinking, all right? So the chest pain, the reader now immediately knows that you were worried about PE on this patient, right? But you could also do versus. I like that sometimes too. Chest pain, MI versus pulmonary embolism. Oh, okay. That means you knew you were treating a chest pain patient, right? And these were the two things that you thought were the most likely in this particular situation. That tells me a lot. Can you say chest pain, MI versus PE as your diagnosis? You can't. You can, but your agency can't bill for it. You've got to anchor on something first. I can't say probable MI. I have to anchor before I can clarify. Okay. Chest pain, boom, billable diagnosis. Myocardial infarction, billable diagnosis. Pulmonary embolism, billable diagnosis. Possible PE, not billable. Right? They just used all of that resources, the money that they paid for the ambulance, everything, and something that you can't bill for now. All right. So you've got to anchor on something. And it should be obvious from where you go. Why? Because your subjective led to your objective, and that all that was super obvious. That's what you put here. And then whatever you put here, you put chest pain. What do I expect to find? Everything else leads from that assessment. If you put chest pain here, I expect to see the treatment plan for chest pain. Okay? If you put myocardial infarction here, I expect the treatment plan for myocardial infarction. Right? If you put atrial fibrillation with rapid ventricular response, I expect the treatment for that, even if you're wrong, right? I would rather you put VTAC and treat VTAC correctly if they don't have VTAC, than put VTAC and then not treat VTAC. You know what I mean? It's okay to be wrong, and it's okay to be specific to the point that you're wrong, right? And you'll learn from that, and that's fine. And you'll be wrong less. I'm wrong sometimes, or sometimes I just don't know. And when I don't know, how do I anchor a diagnosis? As AJ said, I just back up to the chief complaint. What'd they call me for? Chest pain. Did they say they had chest pain? Yes. Well, there's my diagnosis, chest pain, right? It's okay if I feel confident, and I encourage you to do so. I can be more specific, or I can tell you what I think it is. Right? But even if I'm wrong, and that's okay, because everything leads to that, then everything leads from that. So multiple things. They had a syncopal episode. Okay. So syncope as they pass out, right? Syncope, bam, there's a great anchoring diagnosis. Maybe secondary to something, I don't know. Right? Syncope, but then they fell and they hit their head. or then they fell and now their knee's swollen up to the size of a basketball, or then they fell and now their back hurts, right? So now I have multiple things I got to address, because if I just put syncope here, what am I treating? Syncope. So do you treat syncope with fentanyl? You do not. Do you splint syncope? You do not splint syncopes, right? So not only does everything lead to the assessment, but everything leads from the assessment. And I look, when I'm reading the chart, I read both directions, okay? I read ding, 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 ding. It should be obvious what goes here. So if something is going there that's not supported by what's above, I need to change what's above to fix that, not change the facts, but add the correct information, right? I can tell you how oftentimes I get this great history of blah, 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 pain, chest pain history or palpitations or whatever it is. And I get to the assessment that says polysubstance drug abuse. And I'm like, well, then, where did that, I didn't see anything about that up here. That doesn't make any sense at all. Whereas a single sentence might have, fixed that, right? But I'm expecting to see something here. And this should just lead me right to it. And you look at your charts and you read that. Here's my subjective, here's my objective, here's the EKG I did, here's the rhythm strip I did, here's the blood sugar I did. Boom, there's my objective, right? It makes perfect sense. All leads right to it, right? And then you look at your plan. And the plan says, our objective was syncope, and your plan was C-collar, backboard, splinted the left arm, started an IV, gave 50 of fentanyl. And my question is what? We don't do those things for syncope, which means not that they were wrong, but what did you forget? What did you not do?
Put more.
You missed some of the assessment. You need another assessment up there. Okay, syncope and collapse. Syncope, low back strain. Syncope, knee and left knee dislocation, right? Syncope, fall downstairs, closed head injury, neck sprain, or what do you think is the neck cervical fracture, or neck injury, suspect fracture, anchored on something and clarified, right? And then all of a sudden now I'm seeing that, which makes perfect sense, hopefully, based on whatever you put here. And I'm looking here, I say, syncope, I better see a 12 lead, right? I wonder if they checked blood sugar, right? And then, oh, geez, I certainly hope they splinted that knee that they said that was dislocated, right? Oh, God, they're good. That's good. They gave him some fentanyl on the way in, or whatever the case may be, right? I started an IV for the AEMTs, or I splinted in the position of comfort for the BLS providers, right? I mean, I need to be able to see what you did. I gave aspirin because they had chest pain, but they had some sort of a knee injury as well. And so I want to make sure I clarify that. But I will look here and make sure everything you do is reflected in that assessment, by an assessment. That's why often I need more than one, because I need to say everything here should lead right back from there, right? And I look here and I make sure everything that was here leads to that point. If I see something here that's not addressed here, when I'm reading my own charts or reading your chart, now I have questions, okay? If I see a bunch of stuff here that's not supported here, now I have questions, okay? When AJ said, if it wasn't documented, it didn't happen, how many times you heard that? About 1,000, probably by this point in your career, right? If you're a brand new EMT, welcome, you're gonna hear that more. It's not always true, but what is true is if you didn't document it, it's hard to prove it happened. It's really hard to prove it happened, okay? Whether to me, when I'm reading your chart, or whether to Captain Henderson, when he's reading your chart, or to Samantha, when she's reading your chart, or whoever's reading it, or the lawyer in court, who's got it up on a 30-foot screen so everybody can see you misspelled hernia again, right? It needs to be obvious. So that's my goal. When I'm looking at a chart, when I'm writing a chart, that's what I always do. Once I step back from it, I say, I am expecting certain things based on this, right? I want to see those things here, okay? Based on that, plus that, I want to see some things here. Based on those, I'm really looking for specific information and objective finding, right? Do I do sensation and movement in all four extremities on every patient I evaluate? I don't. right? But I certainly do on neck and back injuries, right? Because those made me look for that information. All right, is there numbness? Is there weakness? Geez, they can't feel anything below their navel. I want to know those things, but I'm not necessarily testing them on you if your chief complaint is ear pain, for example, right? I'm going to do a focused exam, but I want some other things in there, right? But make sure that the things, if you were reading this chart and you heard that, the stuff that you would want to know is right there. And then that makes you want to know this. So I want to know that. Make sure that's in there. Make sure that's in there. And then that should be obvious. When you write that assessment, is it obvious at that point? It should be. Okay. If not, you probably need to change something up here to make it obvious. Get me to the same point you're at. Okay. Use that as an opportunity to clarify your medical decision making. You can do a little of that in the plan section too, right? But remember, I've got one or more diagnoses, and there is probably nothing better if I take a single element in your charting that I'm looking at for me to gauge your knowledge level and your competence as an EMS provider. There's no single better indicator probably than that line right there. All right. If yet that line says chest pain every time there's chest pain, oh, okay. I appreciate that. That's an anchoring, that's a billable, that's a reasonable diagnosis. Tells me what protocol you are operating under and what to expect from the plan. So I start seeing clarifications. After I've anchored, I see 3 or 4 diagnoses, assessments, right? I'm saying, this is somebody who's thinking on multiple levels, showing me what they're concerned about, even at the risk of being wrong, what they were thinking, right? And really expands their ability to offer treatment plans. Okay? So both of those things, right? I want to go down to it. Everything leads to the assessment. The assessment better reflect everything, better be perfectly understandable based on what's above it. And then based on that assessment, everything below forms. So every assessment should have something in my plan that I dealt with, right? Everything I did in my plan should go back to one of my assessments. So that's my way of looking at a chart, and that's my way of writing a chart. I want the person who's reading it in an ideal situation to be in my mind exactly as things are going down. Look at that assessment and say, yeah, it makes perfect sense, right? Look at my plan and say, well, of course they did that. Look at that assessment, right? So everything leads to that assessment. Everything leads from that assessment. I encourage you to be bold and put things that are specific, even at the risk of being wrong. If you really think it's a PE, put PE. What if I'm wrong? So what? Right? You told me exactly what you were thinking, and this is where we're going down. I can work with that. Right? Chest pain, suspect PE. A little bit more cautious, right? But tells me you're anchoring on something. I know we're all on the same page. This is what you were thinking. It probably is, right? Shortness of breath is a great example. Lots of things cause shortness of breath, right? This could be shortness of breath, secondary to COVID respiratory failure, or you just put COVID respiratory failure, or secondary COVID-19, or pneumonia, or asthma exacerbation, or the old term of status asthmaticus, or congestive heart failure, right? But put those in. And not only, and this is one of the things I want to say, not only what's exactly going on as a result of their chief complaint, but other things that are influencing that. For example, that patient who's at that bachelor party, got drunk and fell, right? What did they call 911 for? Because he's got a head laceration, right? So I expect to say something like scalp laceration or closed head injury or something like that, right? In your diagnosis list, in your assessment list. But what's influencing that? What's a big influence? Maybe the alcohol intoxication, right? Maybe that's where we're putting polysubstance abuse. Those are the types of things that not just what is it, but what's playing a big factor here, right? And I'm having to deal with. And what's the one thing? If I see that, what else do I need to see? I need to see something supporting that, right? This isn't the place to put alcohol intoxication with no mention of alcohol whatsoever up here, right? But that's easy to do, right? Patient is a bachelor party, admits to a wizard staff of 13 beers. And if you don't know what that is, ask somebody else. Anyway. And then, you know, then boom, number 2, alcohol intoxication. Oh, great. You know, and then I want to see that addressed. How did you address the alcohol? Well, is there anything in your protocol that says how I address alcohol intoxication? Kinda. How about in their medical decision-making? How about in their ability to say, to refuse care? Right? Those might be influencing those types of decisions.
Whether it's trauma and whether it needs to be.
Might be part of your trauma system criteria. Great. Yeah, right. Presence of intoxicants, maybe masking something, for example. Sure. So especially if it influences your care, but if it influences your assessment and it influences your care, if it's contributing strongly to what's going on, there it is. Even if their chief complaint isn't schizophrenia, but schizophrenia is a big part of why they're calling you for that chief complaint. You might want to put that down as an example. Right? All right. So let's take a second. Let's answer any questions if there are any, and then we're going to go back to that one chart that AJ brought up for us. And I know we're going a little over, and I wanted to give a little time for some more question and answers. But you see how I write a chart and this is how I'm looking for a chart. So if you need to take a 5-second break or go pee or stretch your legs or something, we understand.
Scott, did you see that 130 had a question?
I did not. I don't see anything in the chat. Hang on.
No, they had different for a while.
Station 130, did you guys have a question?
Where was your cursor over there?
That, was it like that?
Yeah, that's what.
Oh, was it?
Okay, disregard.
Sorry about
Thank you. Thanks.
They got it.
Station
Nope, there we
130.
go.
So that's all right.
Or did you want
I
the
don't
one
think
from
there's
the
anything
PowerPoint?
Yeah, right.
Doc, do you want to go over the one for that PowerPoint again, or do you want to go? So,
Well, what do you want to do?
I know in Teams, if you have a question, you can actually like raise a hand. So I don't know if you do that.
Sure.
and then we have
Okay.
an AMS report. We can see
Yeah.
that one.
Pick your, since we're going over, pick your one highest yield.
Yeah. Yeah.
Okay. Yeah, no, it's a good one.
We also have
AJ, so
Dr. Hodges,
this is
this is not real, like, it's a question with the times we're in these days.
Sure.
In regards to gender. Subjectively, the gender was given as in your assessment, or would you, if you have something that you believe is pertinent, would you put that in your objective? So like,
That's a super good question. I'm going to paraphrase it. So the question is specifically related to gender, which is described as particularly pertinent these days, for whatever that means, maybe always, but certainly in today's climate. If they say one gender and objectively they appear to be a different gender, it's actually a very similar question to some of the people you go, how old are you, man? I'm 83 years old. You don't look 83 years old, right? Or how old are you, sir? I'm 27. That's a hard 27 years. Objectively, they're going to be different, right? So some of the things I'll do is subjectively what they tell me. They told me they were a 27-year-old male. Boom, there it is. 27-year-old male. 27-year-old male. Objectively, patient appears older than stated age. That's just how it is. And sometimes that happens. Sometimes that can be very relevant, right? If you think it's relevant to the case, I put it down. Right?
you know,
Patient says they are a 38-year-old female. Objectively,
chief complaint, testicular pain.
yeah, maybe,
Well,
right. No.
or-
But what did
or
they
more
say?
important-
Well, what did they
importantly-
say? They said they're a 37-year-old female, right? Subjectively, objectively, patient appears phenotypically male. Okay,
Because more importantly, as I was thinking in the case of 27-year-old male, but you're looking at it and you're going through your assessment and you're really hitting the points where this might be a gestational issue or pregnancy.
oh yeah,
potential.
absolutely. Somebody who
But, you know,
appears male or is identifying as male, but you're actually concerned about pregnancy. Yeah, and so there are legitimate questions and reasonable questions. What was your gender assigned at birth, or what was your gender at birth? For example, can they change? Absolutely. Can they phenotypically change? Absolutely. There are people I cannot, modern hormones and modern surgery, I cannot tell. And I have a lot of medical experience that I cannot tell. All right. So if I'm concerned about that, that's reasonable to ask. And an example of that is a rite of passage that we all had at Akron City Hospital in Akron. And that was a very large male or phenotypically female, dressed as female person would come in very frequently and had a lot of mental health problems, but phenotypically, meaning his actual body presentation, was male genetically male, but appeared female. And the chief complaint was always, I'm having birth. I'm having my baby. Oh God, I'm having my baby. Oh God, I'm going to have my baby now. A big enough belly that seemed reasonable, but we all knew this patient because they'd come in about once a week with the same complaint. And that was fun. We'd throw the intern in there, say, hey, go do a vaginal exam to see if the baby's crowding. And the baby, the spoiler alert, there was never a baby crowding. All right. But so that would be, patient states they are a 37-year-old female. Chief complaint, labor pains, objective, normal adult male genitalia, right? Or whatever that would be. And doesn't that paint a picture for you? You're saying what they said. Yeah, of course, that's subjective. Objectively, I saw this. Does that answer that question for you?
Absolutely.
All right.
100%.
All right.
All right, so we're gonna go over one, and I chose it to be one of mine. Hopefully, it's somewhat comical, and that will help you remember where things go. So this was a call that I went on. So 911 with KPD on scene for a patient that had left the Kirk, right down here, AMA, against medical advice, naked, that was on a psychiatric hold. Patient was detained in the bank and was not cooperating with KPD. Responded code 2 from station 5. On arrival, MHP and officers met us outside and stated the patient had left the Kirk after being there for 30 hours, waiting to go to a facility, and none were open. State the patient is being held with a court order and being ordered to go to a psych facility, and he talked about misspelling things, must return to the Kirk. They also stated she was not cooperating with KPD. We didn't know if she had any allergies, medications, but she does have history of psychiatric behavior. Upon our arrival, patient was handcuffed, sitting on the floor of the bank, attended by KPD and an MHP. Patient had only a bra on and nothing else. KPD had wrapped her in a blanket, which she had also taken off partially. Patient was not alert and oriented was not making sense when she was talking to us. Would not answer questions. We asked and was yelling at EMS and PD, calling everyone rapists. So her head, ears, eyes, nose, and throat equal and normal cephalic. She had no JVD present. She had no obvious deformity noted on her chest or back or abdomen. Extremity, she had good CMS ×4. She had an IV in place in her left AC from the ER. So she left the ER and she still had an IV in place. So we transported psych patient back to the Kirk for KPD due to a court-ordered psychiatric hold. So she's being held with a court-ordered document. She has to stay at that facility until she can be moved to a psychiatric facility. So I'm sure you guys love holding psych patients for 30 hours.
Oh, yeah. Everybody likes that.
Long enough to where everyone kind of relaxes and then they can get away.
Would an assessment be an action? Because you're in your assessment was transport the patient.
Yeah, we're gonna critique it afterwards.
Yeah.
But yeah, keep that in your head and don't forget that one.
So BSI report from KPD and MHP outside. So they met us outside, showed us the documents, explained what was going on, because now we're going to force someone to do something against their will. So we need to make sure that we're doing the right thing. ABC patient contact made. And so if you, we'll wait until we critique it. Contact made, patient was yelling at EMS and PD. Patient advised we were going to take her back to the ER, even though she did not want to go back. Patient picked up ×6-person lift to gurney, covered and secured, KPD stated they could send an officer with us, and handcuffs were placed on the front of her after trying to use soft restraints and the patient fighting with us. Patient to medic 1824 transported code 2 to the Kirk with KPD officer in the back with us due to the handcuffs being placed on the patient. En route, called report to the ER. No vital signs due to the patient telling us not to touch her, and again screaming at EMS, calling EMS rapist. On arrival to ER, patient to ER room she had been in and moved to ER bed without incident. Patient care and report to ER RN, medic 1824 return. So just so you guys know, and this is the same, if I go over a report at an MPD meeting here, whatever, I said on the very first day I ever did this, the only name you will ever see in a report is mine. So if I'm showing you a report that I wrote, I will always show you my name. If I made a mistake, I have no problem showing you that. If I'm showing someone else's report, none of that will be there. Everything will be redacted. So the only name you'll ever see on a report is mine.
Yeah, we do that in chart review all the time, because it takes away some of that subjective or our free stuff. It's like, oh God, this is another AJ chart. You know, I don't know who wrote this chart. I'm gonna read this chart. I don't know who the patient is. That's why it's 2, right? I just read the chart and I say, oh, this is good care. This is what I'm worried about. This could have been documented a little bit better. Boom, feedback goes. Our QA committee doesn't know. The chair knows and writes a letter to that person. You get a letter that the QA committee reviewed your chart. Okay, and blah, 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 blah. I'm sure a lot of you have gotten, or a number of you have gotten letters, right? But you should know that the QA committee didn't know whose chart they were reviewing, right? They just read this chart. It could have been his, it could have been yours, it could have been yours, it could have been yours. They didn't know. Okay? The only person that knew is the chair. And because they have to write a letter to you and say, this is what we found. But let's look through this. Let's scroll up just a little bit.
And that was my idea. Dr. Hodges wanted them all redacted. But I said, if I'm the one reviewing the charts, I want transparency. If I'm reviewing one of my own, I want people to know that that was mine, even if it's not a good one. I feel like that will help.
Yeah, which is a good point. Because like I said before, does a perfect chart exist? If so, I've never written it, right? I've written some pretty good charts, right? But perfect, oh, that's tough. So then I couldn't go through and 6 months later and go, oh, I wish I would have said that differently. Or geez, I wish I would have spelled that differently, or whatever the case is. Sure, right? But we're always trying, and we're trying to get on the good side of that. We had a lot of good chart writers here too. So subjectively, this is kind of what they responded to, right? What am I missing here?
Age,
Age,
gender.
gender. Yeah, we may not have been able to get that in a situation like this, right? What if you have hardly any information up here? Is that ever okay? Sometimes it's okay. What if it's a man down on the street? Nobody saw what happened. I don't know how long he's been down. I don't know his medical history. He's not carrying a thing that says his medications and his allergies, right? Unconscious patients. Oh, they're the best because my subjective is only like this long. Right? That's an easy chart to write. Now my objective better be pretty detailed, right? But subjectively, that's the thing. And so if you're missing some information, what if I have hardly any information from that or whatever? Is that still a billable chart? Sometimes it is. And when is it? It's when you say why. Okay. So it's important to say, it's important to be able to say history and physical exam. One little sentence from you could save your tush from my review, from Captain Henderson's review, or Samantha, or whoever's review, right? From the court, history and physical exam, limited by intoxication, altered mental status, head injury, psychiatric condition, whatever. I mean, I couldn't get a bunch of good information because of this. Oh, that makes perfect sense. Right? And I don't need that. You said why I couldn't get this. Didn't mean you didn't get it. Doesn't mean it wasn't gettable. It just means, doesn't mean you still had to get it. You clarified why. So something in this particular case, you wanted to paint a picture. Does this paint a good picture? Yeah, this is a different type of chart, very different type of chart than we were talking about. But his paints a great picture. Can you all picture yourself there at the bank? with the screaming naked lady calling you a rapist.
Just that Tri-CEO across the street from.
Made it across the street, right? But all this is subjective, okay? Some things you could say not cooperating. What do I want to know? I still want to know what her chief complaint was. What did you get called for? I got it, but I would have liked to have seen a little bit more of altered mental status, bizarre behavior, psychiatric emergency, those types of things, right? Did the patient have any chief complaint? The patient denies injury. Maybe the patient's not able to answer any questions at all because she's too busy yelling at me and not mentally capable of giving a good answer, and for whatever reason at that time, right? But that should be in there, right? This, I would argue, paints a good enough picture that makes it pretty obvious, but sometimes it's better just to put very clearly why that's the case. Objectively, okay, this is super nice. I love this statement. One thing I want to add is, in a situation with a psychiatric patient, nothing says crazy like a crazy person. Use quotes. If anything ever shows up in quotes, that it has to be, you have to be very careful. That's exactly what that patient said in the way they said it, even if it was grammatically incorrect, or that family member or whatever you got that information from, right? And nothing says crazy like crazy people. Sometimes I'll sit and listen to somebody who's clearly psychotic, and I'll just remember what they say, or I'll be I have an advantage. I can sometimes just type it in the room, and I'll just type their stream of consciousness as they're talking about it. And then I've never had it where, and I love it, because then you go back and you read, and you just read this run-on sentence. The patient was started out talking about Hitler, and then they were talking about the black helicopters, and then they were talking about signaling the mothership, and there's this flight of ideas of all over the place. And I could try and describe how crazy they sounded, or I can just quote them. And quoting them is really good. So if it's a psychiatric situation, if it's something unusual, or if it's something that I know is going to be medical legally charged, I love quotations. Love quotations. Careful, don't quote if you're paraphrasing them. Patient said she was assaulted by her boyfriend. Okay. Or patient states, I was assaulted by my boyfriend. Okay, right? I'm not changing the tense. I'm not changing the pronouns, right? Quotes are exactly what they said, even if it's not whatever, right? So I use those a lot in medical legal situations and in psychiatric situations. Love quotes, love quotes. Patient states chief complaint, it feels like a alien mothership landed on my chest, or a spaceship landed on my chest. I had that one time. I'm like, oh, I'm super putting that in the chart. I never forgot that. All right. Past medical history, psychiatric behavior. I don't know what that is, but it gives me an idea. Right? I don't know. What am I missing here? HENT, equal. I don't know what that means. I assume it means eyes, like maybe pupils, right? But it's not clear to me, all right? No JVD, okay, we check JVD on the crazy lady, that's fine. No obvious deformity, no obvious deformity, no obvious deformity, or no trauma seen, right? I'm super interested in somebody acting like this. Do they have signs of head injury? Normal cephalic tells me a lot, right? Remember, everything leads to something. You read this, I'm expecting certain things. What do their pupils look like? Well, I really would have liked to have seen those measured, because this is a lot different. The normal is a lot different to pinpoint, right? Do they have signs of injury? Well, she just ran across the street in April naked. Is she cut up? Did she trip? Are her legs cut up? Did she fall? Did she hit her head? What else is she? Is there an exposure? Is she cold? Those are all the things I'm thinking reading this chart. Back down here. What else? Is this an altered mental status patient? Kind of, right? Behavioral changes can be part of altered mental status. So what might have I liked to have seen? It made me think about a blood sugar, right? Made me think about a blood sugar. Is she diabetic? I don't know. Should the emergency department have figured that out? You would think after 30 hours, somebody would have thought to check that, right? But after 30 hours, things can change too, I don't know if she's diabetic or not. I know she's altered. I know this is really weird. Can hypoglycemia do that? Hypoglycemia can do some weird things, mostly depressed mental status, but some weird things in that in-between stage too, right? So maybe I'd want to see that. I want to see a set of vital signs, but I don't. So what would I expect?
A visual assessment of her chest and respiratory rate.
Yeah,
Signs.
I can count her respiratory rate visually. I can check, she's in handcuffs. I can check the radial pulse, maybe, right? Maybe I can't. And if I can't, because are you not all expecting to see that on a chart? So if it's not there, what do I need?
Didn't happen.
I need an explanation why is what I need, right? Did it happen? I don't know. Maybe, I assume he looked at some. Patient's airway is intact because she's calling me a rapist, right? She appears to be breathing well because she's yelling at me and run-on sentences, all right? So I don't expect a lot of breathing difficulties, but those are the types of things. Unable to perform physical or to get vital signs secondary to lack of patient cooperation. However, she was very vocal and did not appear to be any hemodynamic or respiratory distress. Covered, right? I can't get vital signs on everybody for some reason, right? Well, I can if I work hard enough and use enough ketamine. But that also changes vital signs. Right? So, right. So assessment. You're right. An action is not an assessment. What's your name?
Skylar.
Skylar, right? Action is not an assessment. So I mean, this is accurate, right? But what can you get somebody give me a better assessment?
Can I scroll back to the subjective really quick?
Sure.
Altered mental status.
Sure. Sure. Bizarre behavior. What else? Psychosis. Right. Maybe you're feeling super bold and you're like, I know exactly what this acute exacerbation of schizophrenia. Oh, okay. All right, good for you. All right. Maybe you're wrong, but I know exactly what you were thinking, right? Is it a billable diagnosis? That would be a billable diagnosis, right? And it tells me what path we're going down. Maybe you think she's loopy because she's high on meth. Methamphetamine intoxication. Oh, I've seen this before. This looks like meth intoxication. Altered mental status, bizarre behavior, secondary to meth use, or whatever you thought was related, secondary to a head injury.
Probably combative as well as the soft restraint usage. And then on extremities, was she flailing against the handcuffs or fighting? Would there have been an indication for any chemical restraint if she would have hurt herself with the handcuffs if you weren't able to get the soft restraints on?
Super
And then
good point.
with those in place, that she had distal PMS before or after, anything like that. But the combative and the assessment would be important because you did try soft restraint.
Mhm. Has she injured herself? It's a fantastic point. Has she injured herself with the handcuffs? We work in partnership with the police, right? The police put the handcuffs on, they're going to end up responsible for that. There is a thing called handcuff neuropathy where you can injure the nerve that goes to the thumb. And some other problems. Obviously, we've seen people with abrasions or little lacerations or something as a result of straightening against handcuffs. But that's a great way. That's a nice way to protect the police partners as well. Yeah, I checked. She's got pulse sensation or movement distal to those. There does not appear to be any handcuff related injuries. In fact, I have a template for police clearance or for jail clearance. People show up, right? Bring the crazy person or a person that was drunk and in an accident. They're going to go to jail, but I just need to make sure they're medically okay. I've got a template for that. And in that template, it assumes they're handcuffed. And if they're not, I have to erase that part. And I check for that. And why do I do that? Because I care about the patient. And if that's present, then I need to address that. And two is I'm a partner. These guys are my partners, right? These in public safety. And so I'm helping them out as well. Right. So that's, which is another point we'll talk about later with the fine points of charting, how to chart when things went bad, right? Appropriately so people know what's going on, but limit your liability. All right. So let's scroll down. But all super good points with a combative type patient, right? All right, and did you get everything you needed to from here? Yeah, I pretty much did. Everything here, did everything lead to this? Well, we decided that could have been better, but in a sense, yes, it did lead to that, right? And did everything here make sense based on that? Everything they did made sense based on this. this led to this. Like I say, that could have been better, but it still forms that hourglass. Everything leads to that assessment. Everything that happened is obvious because of that assessment. Okay? So the funny case, sad. Man, I don't want to spend 30 hours in the emergency department. I get paid to be there. So, all right. I went way longer than I thought I was going to. I certainly appreciate all the extra time you guys have been giving me. What I'd like to do is open up for some questions or for some comments and a couple of reiterations. One is we're here to help you guys. And we want to turn this super cool opportunity of being a transport agency and introducing ALS into something that's just going to be fantastic and make it good for you guys and the people that you serve, that call 911 for you and for years. Make your jobs happier and easier, which probably makes Lonnie's job happier and easier. So do you have any questions for me right now? And then after we're done, I know everybody else has stretched their legs or whatever, we're going to hang around. So if you guys have some specific things you want us to know about, or questions you have, whether it's from charting or what we're going to do next, is we're going to be contacting you guys and asking some questions, getting some ideas, the kind of things you guys want to see. You guys have a good program, and we're going to help make it a better program and transition smoother and more efficient. Cool.
I have a question.
Yeah.
Before we got our medicaments, did you do I mean, obviously you reviewed our soaps and stuff like that.
Yes.
Who did you send the things to after you reviewed them?
It depends. So it depends on how they would come to our attention. So I, as the MPD, one of the first things I did when I took over as MPD is I instituted a QA program because there wasn't one previously. So if you make a change, how do you know it improved things if you're not already measuring things and looking at things, right? And so that was a big part of my first steps here was instituting that program. So when there are certain things that I required, one is that all charts are reviewed, and I let the agencies specify how that's going to happen, because your guys' resources and your guys' patterns and what works for you guys is not necessarily the same thing that works for County Fire, right? I mean, don't get me wrong, there's a lot of overlap, right? But it's just not the same. It's not the same. If it works for Prosser, maybe it doesn't work for Richland, or that kind of thing. So I kind of left a lot of that in the hands of the agency with a hierarchy for referrals, right? You got an EMS officer, which is one of the things, Darren took over, which I love. And by the way, I got to say, I love the fact that the EMS officer is not a paramedic, because I want to really empower the BLS and the ILS providers. You okay, Darren? I got to say it because almost every other one is paramedic. And there's certainly a natural thing there. But I love the fact that the majority of the providers are BLS providers, right? There's ALS providers and there's ILS providers, but that the person in charge of it is the most representative of the BLS providers. Is he going to have some hurdles to overcome to take a look at ALS charting? Absolutely. And is there some things we can put into place and that are already in place to do that? Absolutely. But I really like the fact that that's what's represented. If you got 2 paramedics and the EMS, and 30 basics and 6 EMTs, but the EMS supervisor is a paramedic, well, that can kind of skew things. But you guys are BLS agencies still, right? I mean, look at all the great BLS care you're given, ALS care you're given, and the ILS care that you're given. So I just wanted to say that because it was pretty bold. I don't know how that decision came about. I haven't asked Lonnie and Darren about it, but it was pretty bold and I like it. So, but it does present challenges for them. All right, so the answer is when it gets to the level of the MPD office or the county QA/QI committee, then every chart that gets reviewed gets a letter back to that provider. There is no letter to Darren unless it was his patient. There's no letter to Lonnie unless Lonnie was the provider of that patient. So it's also protected from Lonnie. Lonnie has no ability or right to see the results of that QA review process because that's between you and me, right? Now, don't get me wrong. If we see a pattern and there's a problem, we'll help you address that. And I may need an agency officer to help with that. But in 14 years, I'm not sure if that's ever happened. So that's your medical care is between you and me, and I can fix a medical problem or a lack of information, right? And I'm a big fan. Sometimes everybody makes mistakes, including me, right? And I also know that the person least likely to make that mistake a second time is the person who made it the first time, right? And learn from it. If you make a mistake, we talk about it, like, yeah, I knew right away, right? Yeah, I of course I should have checked the blood sugar on that patient. I don't know what I was thinking. Well, who's least likely to ever forget that again? You are, right? I give an example of when I was an intern, and I should have known better. I'd already been a paramedic for 8 years or something like that. I'm an intern physician. The patient's having a seizure in the emergency department. I'm trying to manage this an hour and a half into my list of medications to try and stop a seizure. I get the labs back from the lab that showed a blood sugar of 19. I'm like, I probably could have fixed the seizure a lot earlier if I'd have thought to check a blood sugar. So now, who's famous for asking blood sugars all the time? I am. And why? Because I made that mistake before, and I'm the least likely guy to probably make that mistake again. If you make a mistake and don't own up to it and refuse to see that there's been a mistake made, I don't know what to do with that. I can't fix that. A lack of information, some trouble with medical decision making. Yeah, we can fix that. Sure. Let's talk about congestive heart failure for a little while. Here, this is why that didn't go well. Oh, that makes sense. Next time I see that problem, I'm gonna do something different. Beautiful. You and I are friends. That's exactly what I need to see, right? But, and so that's why I like to keep it separate. Mistakes are almost always an information or sometimes a judgment error, right? I didn't have the right information, or I had the information, but I made the wrong conclusion, or whatever. I can fix that. Yeah. Let's sit down and talk about that problem for a little bit. Boom. Now I know you're the guy that I want treating congestive heart failure, because we just went through that, and I know you know it now, right? So that's the way I look at things. I'm going to make mistakes. You're going to make mistakes. I promise not to judge you on your mistakes. I hope you don't judge me too hard on my mistakes. But what I will judge you on is what you do after that mistake, right? You own up to it. Try and better yourself. Try not to make that mistake again. That's perfect. Absolutely perfect. I don't care you made a mistake. I care that you learned from it and we're able to do so. And in the same way, I make a mistake. I hope that I own up to that, figure out what went wrong, correct any errors in judgment or errors in knowledge deficiencies, and not do that again. All right, so that's kind of where that goes. But if it ever gets to the point of the county CQI committee or the MPD office, you're going to get a letter. Your boss is not going to get a letter. It's just going to be you. Be confidential. Say, hey, we reviewed this. This is what we found, right? It might say, we thought you gave great care. It might just be a kudos letter. In fact, we do that a lot, right? It might be, please consider on your next altered mental status patient, checking a blood sugar, or whatever the case may be. But, and it's also being reviewed by peers. Sometimes I'll talk to you directly, especially if I have very specific questions or concerns. But I don't get a vote. AJ's on the committee. Darren's on the committee. I don't get a vote. I'm the doctor. If there's a tie, I get a vote. But otherwise, I'm not grading you because I'm not an EMT. All right, this is only being judged by your peers. So, don't get me wrong. I can comment on a case, but I don't actually get a vote unless there's a tie, and then I get the tie-breaking vote. Woo-hoo. But it never happens, or almost never happens. Good questions. I went a little far afield with that, but I hope I answered the original question. Other questions about it. And part of what we're going to do, what our goal is over the next few months, is to refine the current QA process within Benton County Fire District 1 and make it more useful, easier, and make it more useful to not just Darren as your EMS officer and me as the MPD, but for you guys. How do I look at a chart? Because I want you to look at his charts, or whatever, or you to look at her charts and be able to give meaningful comments, right? And meaningful help. You're on my team, right? Here's how I would do that. And when you read a chart, one of the best things I ever did was volunteered for the hospital and the emergency department's chart review process, because I learned so much. I'm reading somebody else's chart, and I can't tell you how often I look at a chart and go, ooh, I like the way they said that. You know, I'm going to use that. Oh my gosh, that's fantastic. Or sometimes it's like, I will never write that in my chart. You know, but those types of things. But here, not just this phrase is awful, that's not helpful, right? Maybe this is a better way to do it, right? Or question, you know, some simple stuff like, hey, should you check the blood sugar here? Were you going off of altered mental status? Because I was looking at that, and that led me to think I was looking for a blood sugar. I never saw it, right? But so those types of things. And what's stylistic difference? Because they're here in paramedic school, right? So the way you practice is going to be a little bit different than the way you practice, right? It's going to be a little bit different than the way Samantha practices, right? So, and the way you document is going to be different. When I write a chart, it doesn't look the same as AJ's chart. They both may be fantastic charts. They both may be terrible charts, but they'll be different, right? So what's really important and what is a stylistic thing? Because there's a lot of right ways to do things. And so that's some of the things we'll be talking about. What are the right ways to do things? What's important enough to need a change, right? If there's a billing concern, if you're missing a big billing point, guess what? You're going to get a letter and you're going to put something in to fix it, right? And you're probably not going to make that mistake again, right? But you write it, I wouldn't have said it that way, but I understand what you were doing. Or maybe that's not something you need to change. That's just his style. His charts don't look exactly like my charts, but they should convey the same information, or the same information well. And while you're reading those charts, look at those and say, man, I like that phrase. Or especially like it with refusals or against medical advice charts. I really look hard at the way other people are documenting that stuff and think, ooh, I like the way they said that. I'm going to kind of cut and paste and steal that, you know, that type of stuff. That's a great example. Those charts are hard to write. We'll have a whole session to talk about refusals sometime. Other questions? Darren.
Could you go over a little bit just on addendums and?
Oh, thank you. Thank you. We had talked about that to make sure we didn't do it, or make sure we did it. So an addendum. So I've written a chart, signed that chart, and now I got some new information, or I'm going back over it and I'm like, oh crap, I want to put something in. How do I address that? So it depends, because you can go back into a chart, right? You can go back into a chart in some cases 3 months later and put something in. So when do I go into a chart? And if I do, how do I do it in a proper manner? How do I change a chart in a proper manner? And here's the answer. If I've gone in and I just got a little quick with that sign button, right? And then 2 minutes later, or 3 minutes later, or 20 minutes later, I'm like, oh, shoot, right. I can go back in and I can reasonably just edit whatever I wanted. Or I'm rereading it and I'm like, oh, I forgot that. Or that doesn't make any sense. I better clarify that. Or I forgot to put the blood sugar in, but I did get the blood sugar. Here it is right here. You know, those types of things. If it's almost right away, and there's no hard and fast rule, but certainly it needs to be less than 24 hours, right? There's no hard and fast rule because I know how some of the shifts are. You know, if you're going boom, 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 like a lot of the Kenwick shifts, right? It may be 6 hours later, I'm sitting down to be able to clarify some of that stuff in that chart, or even finish the chart sometimes. Not ideal, obviously, right? But if it's reasonably quickly and it's something that was immediately available to you at the time, go back into that chart, edit whatever you need, okay? Sign it again. Sometimes the charts will put little time signatures when you sign. Don't ever erase that one and put another one. You know, let it put a second one underneath it. So, oh, I went back in. Now, let's say it was something due to a chart review. The chart was closed, the chart was signed. You come back to your next shift 3 days later, and somebody has left you a little note saying, hey, I looked over your chart and I noticed that you forgot to document the rhythm interpretation, right? And you know, they're like, well, did you do one? Well, yeah, I have them on the monitor. Oh, it's sinus tach with no ectopy. Oh, okay. I want to go back in. I want to put that in there. But it's been long enough now, you should probably not go back in and edit the original. So what you do is you do an addendum. At the very bottom of your chart, don't touch anything above. Below your signature, say time and date or whatever it is, right? Clarification. A rhythm strip interpreted at at the time of the call was sinus tachycardia at 135, no ectopy. Fine. Okay. That's a great example of something that is found during systematic review from your agency where you would want to maybe go back in and say something. But if it's been more than a few hours, certainly if it's been more than 24 hours, do it as an addendum. Don't change anything above that. That makes sense? This stands by itself. I just want to clarify something here down below, but I didn't change anything here. Okay?
Dr. Hogan,
Yeah,
we have a separate addendum box that's actually timestamped within our system. That's all
Beautiful.
approved. So we have them write C attached addendum, and then they actually go into a menu with an actual addendum box.
beautiful. So your specific hardware, your specific software addresses that. Now let's take another example. Okay, let's do the other extreme example. Is now I got a subpoena. All right, I got a subpoena saying I am going to have to give a deposition based on this. Maybe it was an assault or a rape victim or sorry, rape call that went on. Right. Of course, there's going to be a prosecuting attorney or somebody that's going to want to talk to me about this. That shouldn't surprise me at all. Right. So what was the first thing you do when you get one? You're like, geez, that was 4 months ago. I don't remember this case. Or I'm going to go back and I'm going to read my chart. And I go back and I read my chart and I'm like, ooh, I really should have documented this. Right. Is that the time to go in and change your chart? No, you're done. You are done. That chart never gets changed. Okay. If you go back in and you read the chart, you can and say, ooh, I actually did this. I forgot to document it. I remember it now, reading my own chart, and I wish I would have documented it differently. Write that down on a separate piece of paper. Talk it over with the attorneys. Never go back in and change the chart. Okay, whether you're being subpoenaed as the defendant or just as a witness, right? And the vast majority of the time, it doesn't happen that often for you guys, but when it's going to happen, 99 times out of 100, you guys are going to be a witness in the case that they want to talk to, not the person who's being sued or the defendant in the case. But under no circumstances, because of a subpoena, should you go in and change anything in the chart, even an addendum at that point. Just write down what you think is important and share that with the attorney as is appropriate. All right. That's important if you're a witness, but it's especially important if you're going to be the defendant too. Okay. And then of course you share that with your attorney, right? And or the agency's attorney, right? So those are the 3 times. It's right away. I need to clarify. Sure, jump right back in, fix it. Okay. It's been a few hours or it's been long enough that I'm reading through the chart. I'm responding to somebody else's feedback, addendum. Okay. It's been a long time. I might make some personal notes on it. It's been a long time and or it's because of some sort of legal action. That chart doesn't get touched. You could look at it, absolutely, but does no editing, absolutely no editing. All right. Just write down whatever you think is important or what actually happened or what you remember, totally okay. And then share that with the appropriate attorney. So that's the addendum question, which is a fantastic question. Thank you for reminding us about that because that was on both of our agendas and we forgot. Other questions? No questions from,
No questions coming in from the Zoom crowd so
man, you
far.
guys are boring. Especially you, Darren. All righty. Well, I'm going to hang around. I don't know if Chief Click or